But I'm going to talk about anterior instability in athletes. And purposely, I talk fast, so there'll be plenty of time for questions, but I'll definitely try to slow it down. But, kind of, obviously, we'll talk about anterior instability, focusing on athletes. A lot of this will be review, but typically affecting, kind of patients, and what we're focusing on here, 15 to 40 years old. And it's pretty common, especially when all of you here are dealing with athletes, from football goalies to basketball, volleyball, handball. All of these are going to be at risk for shoulder instability. And the shoulder in particular is an issue because there's greater range of motion, less constraint, but inherently that implies less stability. So, you kind of take the good with the bad. A couple of things help stabilize the shoulder, and these are going to factor into our decision. It's key to have a good understanding of them because it's really going to factor into whom we decide to treat and how we decide to treat those patients with instability. Obviously, there are the static stabilizers, the bone and the labrum, the capsule, and then the more dynamic stabilizers, the rotator cuff, pec, lat, and deltoid. When we focus on anterior instability, the main lesion that we classically discuss is the Bankart lesion, and that's classically described by Bankart years ago as the avulsion of the anterior inferior labrum with the IGHL attached. It's seen in almost 90% of traumatic dislocations, and sometimes it can come off the bony fragment, which we'll focus on as well. And then the Hill-Sachs lesion, which I'm going to spend a decent amount of time talking about because even, now I'm old, but I'd say even as recently as when I was a resident, this was just sort of considered an incidental finding. You'd see a sort of an osteochondral compression fracture of the posterior lateral humeral head. We'd see it on x-ray, and we would just sort of assume that, it was further proof, almost like a bone bruise in a knee when you see an ACL tear, that an instability episode had occurred. But that was really sort of the extent of the credence that we gave it. And that's that on x-ray, that the sort of the dent on that posterior lateral compression fracture. I mentioned that Bankart lesion is kind of really pathognomonic of anterior shoulder instability. Obviously, a graphical depiction on the right there, and then the MR findings. So just to orient you, this is an axial view, humeral head, glenoid. This is the posterior labrum, which looks good. And as I explained it to patients, and not to speak down to anybody, but I talk to everybody the same way, nice black little triangle there, which is the labrum. And we're not seeing that in the front, and that's that tear. So this is what you typically see when somebody comes in who's dislocated their shoulder. The issue then becomes, what do we do next? Particularly as it pertains to an athlete, the issue is, can they, oftentimes, and I'm sure you've all received this question, can they return to play this season? Or should the shoulder be stabilized surgically initially? And there are a lot of variables here that will help us answer that question. In terms of background, it's really good to have this. I thought was a great study that just gives you sort of age sort of related risk of recurrent instability. So obviously, as you get older, working backwards, you get over the age of 35, we get stiffer. I have to stretch in the morning before putting socks on without throwing my back out. So I'm going to have a less risk of dislocating my shoulder. But, and you also have less exposures. I'm not playing sports every day. You're not playing tackle football. So for a lot of reasons, there's a much lower risk of dislocating your shoulder a second time if the first one happens at the age of 35. The flip side is, if you look at a 15-year-old male on this chart, almost a 90% chance. And, and the cutoff, kind of at 50% is at 27. But this is really the age group that we're talking about, this kind of 15 to 25-year-old group. These are the athletes that we're seeing. And these are the ones that we know are going to be at a much higher risk for recurrent instability. Another just sort of side comment, which I think is becoming a little bit more appreciated now, is that we discussed that when you dislocate your shoulder, that pathognomonic lesion, that happens kind of almost 90% of the time, is that Bankart lesion, that labral tear anterior inferiorly. Even if patients don't redislocate their shoulder, if they don't have recurrent instability episodes, there's a small percentage who, depending on the sport they like to play, if it's a thrower, a volleyball, somebody who spikes with their right arm and it's their right shoulder, a baseball player, even if they don't have recurrent instability episodes, there is the potential that a few percent of them are going to have pain from that labral tear. So there's almost a 90% chance that this 15-year-old is going to redislocate again. But when I see this in baseball players, I tell them it's probably even higher than that the shoulder is going to be symptomatic. So again, this is going to factor in to our decision-making process. And I think, most would agree now, and this is, again, changed since when I first trained, first-time dislocators, contact athletes younger, we're really going to even at that point, after the first dislocation, discuss fixing them, which, previously we'd say, okay, let them declare themselves to be a recurrent dislocator. I think we've learned that it's probably going to happen again, but also each time somebody dislocates their shoulder, it's not a benign event. Things can tear worse. You can lead to sort of, instead of it just being a labral tear, maybe there's some bone loss. And as you'll see, that really affects what we may have to do in the operating room if it goes there. This is a systematic review from Rob Brophy, and it's from years ago, but it makes the point that looking at recurrence, if we treat these first-time dislocators conservatively versus fixing them surgically the first time, a much lower rate of recurrence with surgery. Basically a 1 in 2 chance that it's going to recur with conservative treatment versus a 10% chance of recurrence with surgery. And so this really kind of set the stage initially for saying maybe we should get a little more aggressive about fixing these. This is a study done in the military where they've got a good sort of group of it's a nice controlled setting where they're not losing patients to follow-up. They're young athletes. They're typically managed the same way. So it becomes a nice place to do prospective multi-center studies, which we don't typically have, in America and in sports in particular. This looked at successful return to sport after arthroscopic stabilization versus non-operative management. And again, they looked at contact athletes, about 40 athletes, 10 were treated non-operatively, 40% were able to return to play. 30 of them were treated with an arthroscopic bank cart and 90% got back to play. So 5 times or almost 6 times more likely to have a stable shoulder if managed surgically. To further the point, this is looking at first-time instability. Again, this top study there was also from the military, looking at a prospective randomized arthroscopic versus non-operative treatment. And in general, they treated most non-operatively, but a much higher recurrent risk. And the group from Sweden showed that you can consider more aggressive treatment in a select. They kind of tried to get a little more granular, showing that, more contact athletes, maybe those you're going to want to treat first time. Again, I think now really the conventional wisdom, and it's we say it joking, it's a terrible joke, so I'm almost embarrassed to repeat out loud, but the comment is you don't have to treat them after their first dislocation, but definitely before their second dislocation. I can't believe that got a chuckle. It doesn't deserve one. It's not funny. But it's, that is kind of our, really where our mindset is at this point. What about going back to play in season? Because this is the question you'll get a lot as a shoulder surgeon, somebody treating this. It's, especially, I don't know what it's like here in America, in New York, everybody thinks their kid's going to be a professional baseball player or in the NFL, or at the very least, get a big Division I scholarship with a nil deal. So it's imperative they never want to be out. They have to play every sport, for hours a day, 12 months of the year. So you can imagine that when they get injured and I tell them they've got to be out and potentially need surgery, that is not taken well. And even telling them that they miss a junior high school football game, that's not taken well either. So this is always a discussion. And it's good to have data to kind of back up what we're recommending. And I think when they talk about returning to play in season, we looked at non-operative managements. This is Dan Buss, who was a resident at HSS, and he looked at non-operative management for in-season athletes. These were basically football players, American football, with an in-season event of first-time shoulder instability. 30 athletes, 26 got back very quickly, kind of a week and a half later, and they based that on just return of full range of motion and strength, and at that point they said it was safe. The problem is almost 40% of them had another dislocation during the season. So you're really risking, further injury. And that's got to be made clear to the parents and the coaches and the trainers and everybody, and the athlete themselves, obviously. This is another study, again, from the military, from the West Point, where they looked at 45 college athletes with anterior instability. 3/4 of them were able to return to sport, but a huge number had recurrent instability during that season. And only a small number, 1 in 4, were able to complete the season without recurrence. And some of those only had a few weeks left. So again, neither of these studies really inspire confidence to say that you're going to get this athlete through the season without another event. And again, all the more reason why we just say, we're trending towards saying you had a dislocation, shut it down, fix it, be ready for your spring season or whatever it is so that you don't make things worse. So I think to conclude on, should we let them back during season? They can, but again, be very aware of the risks. And, in good conscience, it's not something that I would recommend, particularly in these younger athletes. Obviously, in the NFL or the NBA, they have different reasons and motivations for playing. There's a lot more money at stake. There's a lot of other issues that factor in, and they, for them, the risks may outweigh, the benefits may outweigh the risks. But when you're talking about, high school, college students who just want to have a kind of a normal shoulder for the rest of their life, I think shutting it down and fixing it gives them the most predictable outcome. So what are our surgical options? Well, classically, years ago, even before I trained, it would be an open stabilization and open Bankart repair, and we'll talk about it. And it's funny because I used to have a few slides on this just for for historical context. But like most things in orthopedics, because we don't have great data and we just try to get creative, what's old is new again, and we're definitely seeing a trend towards more open stabilizations being done over the last few years. On the right is just a picture of our classic kind of go-to now, and I'm sure you see this all the time here, just an arthroscopic stabilization, and that works really well, but maybe not as well as we think it has, which is why we'll talk about some other options. The open Bankart repair for years was the gold standard, and really just, again, we discussed that the pathognomonic lesion was that tearing of the labrum and inferior glenohumeral ligament away from the glenoid. Here you would then tighten the capsule. And if we looked at it as described in the initial series, 90 to 97% good to excellent results more than a decade after surgery, and 3 to 5% had recurrent instability. So, pretty good results. This was looking at open Bankart for the treatment of anterior instability without glenoid bone loss. And again, good results, relative to recurrent instability risks. Early 90s, we started to switch, arthroscopic surgery became popular. The implants were developed to allow this to be done arthroscopically and not have to do open surgery. And you don't want things to be technology over reason. The initial recurrence rates were anywhere, 16 to 44%. So clearly, just because you could do something arthroscopically initially, that was much worse than our results open. So I think it made us give pause and start looking at kind of improving our techniques instead of using transosseous or transglenoid sutures or metal anchors. Different implant companies have come up with different ways to do it. And because of that, results have improved, as we'll see. One thing I did find interesting, just to kind of make the point that, technology drives a lot of what we do. I just saw an interesting study showing the results of rotator cuff repairs since the mid-90s to now. And if we look at kind of all the patient-specific outcomes, healing rates, really no change. It's all been about 90%, to oversimplify, despite advances in technology. Now we can do things more minimally invasive and more quickly than we could 30 years ago with big open surgery, but our ultimate outcomes have not really improved significantly, which is, a little depressing and makes us think that we'll have to go back to the drawing board to really get even better results. This just, kind of is a study showing kind of patterns of treatment patterns in the United States. And they were probably, I would say they were mirrored worldwide, but, in Europe, they've been doing a Latarjet procedure, which we'll talk about here for years. So probably doesn't apply everywhere in the world, but especially in America, as implants improved, as our surgical techniques improved, imaging improved, 90% of the stabilizations were done arthroscopically. And as we did that, the results, will show got at least equivalent to the open. But let's talk about the risks and benefits first. Obviously, with an arthroscopic Bankart, quicker surgical time, less blood loss. This study said earlier range of motion. I don't do that. I mean, my postoperative course is the same, which we can talk about. But when you look at the advantages, you want to make sure that, we were getting the same consistent results that you were getting with the open Bankart. Because again, the very low traditional recurrence rate with the open surgery. There's clearly challenges. Obviously, open surgery has the risks of bleeding, infection. Maybe we make them too tight, which is why there was a decreased recurrence rate, but there was more motion loss. And the flip side is on an arthroscopic Bankart side, dealing with sort of more complex pathologies, maybe bone loss, as we'll talk about, Hagel lesions. Those are things that, maybe were more difficult to treat arthroscopically. So I think this makes the point that while there's risks and benefits of each, or advantages and disadvantages of each, I think you should have both in your armamentarium. That said, again, as we started to get better, surgically, you want to make sure that it's not technology over reason. So we wanted to make sure that as you start to do things arthroscopically more frequently, we're not taking a step back in terms of our ultimate results. And this looked at, early term, 2 years after arthroscopic stabilization, same results, which was sort of at least good news for the arthroscopic group. This looked at long-term outcomes after Bankart shoulder stabilization. It's the group from Rush, and this was published in 2013. So at least we're getting towards a bit more modern arthroscopic techniques. So probably a more relevant comparison. And they looked at 26 studies and really slightly earlier recurrence rate for arthroscopic, but everything else was not statistically significantly different in terms of outcomes. How about return to play after arthroscopic surgery? Again, we're talking about athletes here. Just because you can do something sort of more quickly or easily, if we're not going to get athletes ultimately back to their previous level of play, then we're not really helping them. And this was a study by Dr. Andrews in Alabama, one of the most famous sports medicine surgeons, looking at return to play in professional football players and high-level college football players, 33 players that were followed for 6 years. And it was a tough group because A, it's football, which is one of the most high risks for shoulder instability. And also a third of the group had prior arthroscopic or open stabilizations. And they had an unbelievable, overall stability rate at 6 years of 97%. I don't know what they were doing different than everyone else. It's almost too good. But I think it at least made the point that, arthroscopic Bankart could get athletes back, the highest level athletes, back to their previous level of play. Another study looking, this was to kind of be a bit more sobering. This was the study from HSS. We looked at our data. Now, again, this was published in 2010. So to give some context, you're looking at results or surgical techniques kind of used sort of 2005 or 2004 to 2008, which were still earlier arthroscopic techniques. We've definitely improved them. We've made it stronger. Arthroscopic techniques are better, but that's not to discount the findings here. And I think looking at it, honestly, we had 83 patients, arthroscopic Bankart repair with suture anchors, almost a 20% recurrence rate. So not very good at all by a group that we think were pretty good, surgeons. So 18% recurrence rate, 7 were frank dislocations, 6 were subluxations. And a lot, look, again, these were return to contact sports. 2 had traumatic redislocations. And even when I see patients in the office, if we fix them, a part of it is sort of counseling afterwards where I explain to them that we're not making you into Wolverine. You're not indestructible. If you're going to go back and play football, if you're going to go skiing and do jumps and stuff, just like the shoulder that you were born with, was able to dislocate, even after we fixed it, you clearly still have that risk. But an 18% recurrence rate, again, it was sobering. And I think the good news about it was that it made us kind of look a little more granularly as to why and what can we do differently. In this study, we looked at the risk factors for recurrent anterior instability. I mentioned earlier that Hill-Sachs lesion that we, for years just sort of thought of as an incidental finding. This was one of the first studies to show that a larger Hill-Sachs lesion clearly had predisposed a patient for a recurrent risk for instability. Younger patients, again, goes with that initial chart for a lot of reasons, but younger patients under the age of 25 had a higher risk of recurrent instability. Underlying ligamentous laxity and contact sports. Other studies have also looked to try to figure out who's going to fail, because that's really the issue. Who's going to fail, because that's the group that we're going to have to do more for. And this looked at, recurrent dislocations. It was a study of 77 patients undergoing previous arthroscopic Bankart repair. 63 were stabilized after their first dislocation and 14 after 2 dislocations. At a 3-year follow-up, this is what my terrible joke before that got a few chuckles. At 3-year follow-up, they looked at the rate of recurrent dislocation. It was 43%, if you look at that middle kind of column there, if they had 2 dislocations, if they were stabilized after their second dislocation, whereas it was only 14% if they were stabilized after their first dislocation. So that's a huge difference, sort of 3x, waiting from that first to second dislocation. So it's really not, a benign thing to just have them, say, let's see what happens. We'll fix you after your second dislocation. No difference in sort of range of motion or outcome scores, but I think they concluded, correctly that overall stabilization after a first-time dislocation reduces the risk of recurrent dislocation compared to, waiting till a second or even more. Other risk factors in several studies, contact athletes, as I mentioned, this looked at, a failure rate of almost 2 to 3x higher in contact athletes. I showed that initial study earlier where men are at a much higher risk of recurrent instability than females. Younger age, I just mentioned that we saw that in the HSS study, and it's been seen in other studies as well. The number of previous dislocations, again, a big jump from 1 to 2, and then glenoid bone loss. Glenoid bone loss can occur in a couple of different ways, really 3 different ways. One is that bony Bankart lesion, where when you dislocate that first time traumatically, not only do you take the labrum off anterior inferiorly, but you take a chunk of the anterior inferior glenoid, like you see on that left there. Sometimes you get this more attritional bone loss, where just from repeated dislocations, it's almost like sandpaper to a piece of wood, where it just slowly wears it away. And while it's not a big chunk like you see on the left, it's enough to cause effects to the kind of way the humerus articulates on the glenoid. The final way is what's been described as sort of an inverted pear. So sometimes when you look at an A would look pear-shaped. There are clearly people who have what's called an inverted pear. And as you can imagine, you've got sort of left surface area at the bottom of that glenoid when it's an inverted pear shape, which is kind of tantamount or equivalent to just losing bone from a Bankart lesion. This was a study looking at, again, predictors of failure. They looked at traumatic glenohumeral bone defects and their relationship to failure of an arthroscopic Bankart repair. They found that patients without bone loss had a very low recurrence. This is a study by Steve Burkhart and Joe DeBeer. And it's, again, it was an early study done, at this point almost, kind of 18 or 20 years ago. And I think it did a great job of making us realize, the pendulum had really swung a lot of places to going from an open stabilization to an arthroscopic stabilization basically all the time. This study made us realize, and I think it crystallized that, okay, not everybody's going to do well with that. And we really have to get more sophisticated in our approach to treating instability. They looked at patients without bone loss, and there was used an arthroscopic Bankart repair, and they had a 4% recurrence rate, which is great. Patients with bone loss, however, had an almost 70% recurrence rate. So, and to compound this, if you took a contact athlete, in their group, they're from South Africa, a lot of rugby players, a contact athlete with a bone defect, it was almost a foregone conclusion that they were going to recur with an arthroscopic stabilization. So this study really kind of, made us think about how we're treating these, and it really popularized the Latarjet procedure in America, heretofore where it really only been done in Europe and sort of outside of the United States. Now we realize that we better put this back in our armamentarium because what we're doing is not working well. Other studies have shown that there's a clear relationship between glenoid bone loss with a failure of arthroscopic Bankart. And our numbers, as you'll see in this talk, have really shifted. At first we said, okay, more than 25% glenoid bone loss, maybe we should start thinking about doing more. If you think about it, taking away a quarter of that inferior glenoid is a big chunk of bone. And, at this point, everybody would agree that 25% needs more than an arthroscopic. But as you'll see, we've really sort of, that number has trended downwards to 10 or 12% now, and maybe even less every time I give this talk. But if you look at, they looked at several different studies comparing arthroscopic stabilization, Bankart, in patients with and without bone loss. On the left is without bone loss, so this kind of 4, 15, 23%, and you compare that to those with a bony defect, and the numbers aren't even close. So again, arthroscopic in the setting of bone loss is definitely not enough. This study looked at the effect of subcritical bone loss. So again, smaller bone loss, they had, again, less than that 25%, but now we're going down 20 and looking at 20% and 13.5%. So trending down, as I was alluding to. And they looked at 50 collegiate football players. If they had a very large bone loss, it was excluded. Because again, at this point, we've already realized that it's not going to work well. They looked at shoulders with 13.5% glenoid bone loss. So almost half of what had been used, before this. Those with more than 13.5% glenoid bone loss had recurrent instability, all of them. Whereas those with less had no recurrent instability. So again, we're trying to find that number that, helps us make decisions in the operating room or even before surgery to give our patients the best outcome. And this study did a good job of, again, trying to get that number down from 25% to, a more manageable 13%. So how are we dealing with this? Well, again, just looking at glenoid bone loss, if there's none, arthroscopic Bankart works great. And even, up to 13.5% in some studies, arthroscopic Bankart works great. That said, as we'll talk about in a few minutes, I think that, that 13.5 group is clearly at a higher risk than somebody with no bone loss. And so maybe we should do a little more, which we'll talk about. Most would agree at this point that once you get above 20% on the glenoid, we're going to do a Latarjet or at this point, maybe even like a distal tibial allograft, something to replace the bone that's been lost. The Latarjet was described by a French surgeon, Latarjet, and it really, it's not just taking the coracoid and attaching it to the glenoid, or and basically when I explain that to a patient, we're basically taking what's typically a golf ball and a golf tee. That's how the analogy is to explain a shoulder. I say, it's unstable. Now we're going to put that golf ball on a saucer. We're going to make that tee bigger by adding bone to it. And again, definitely an oversimplification, because the Latarjet, while it does work with a bony effect, as you see on the right over here, where we're bringing the coracoid to that area of bone loss, it also works as a sling effect where the conjoint tendon is lowering the inferior half of the subscapularis when you put the shoulder into that sort of at-risk or apprehension position. And we're reinforcing the capsule by using it with the CA ligament. So he described the triple effect. And, when you look at the results, Jill Walsh has, 96, 97% great results using a Latarjet for anterior instability. Now, they did that for everybody. It was all comers. And, again, our bias was always this is a little bit more invasive. There's definitely, as you'll see, higher risks. So while it works great for everybody, maybe everybody doesn't need this to get the same outcome. That said, I think, we've been talking a lot about glenoid bone loss, and that overlooks the fact that, as I mentioned, the humeral head is a real issue. It's not just this sort of incidental finding. Hill-Sachs defects play a significant role, and now we're really appreciating that in sort of recurrent instability or failure of stabilizations. So, arthroscopic Bankart works great for these low risk, Latarjet for high, but let's focus on this sort of higher risk, where we acknowledge the limitations of an arthroscopic Bankart and realize that we have to do a little more. Recently popularized is the glenoid tract concept. And what this does is it really kind of combines glenoid bone loss with humeral or Hill-Sachs bone loss. And this was a great explanation as it was explained to me, because I'm not very smart. So this made it sort of simple and a little bit easier to sort of understand. You think of the glenoid tract as your tire, and the Hill-Sachs is your pothole. So you basically need a big tire diameter, bigger than the pothole, or you're going to fall in the pothole and crash. So, that's a bad situation. You need the tire to be bigger than the pothole, or it's going to crash. Now, if you have a bony Bankart, that tire diameter gets even smaller. So now both your tire diameter and your pothole size matter. So to just look at one or the other in isolation is a problem, and it's not going to lead to a good situation. This is just what you'd see at the time of surgery arthroscopically. So this is the view looking from sort of an anterior superior portal, but basically looking down a glenoid. And this is that anterior inferior aspect of the glenoid antero that's missing bone. And then this is that Hill-Sachs defect there. And you can see that it's as we bring that shoulder into that, 90-90 position, where like a throwing position, the humeral head is basically dislocating into that Hill-Sachs lesion off the anterior aspect of the glenoid. So that would be considered an off-track lesion. That's, the tire driving into a pothole, which doesn't feel good for patients and doesn't portend a good diagnosis, or if we just try to treat this arthroscopically. To validate this, the glenoid tract concept, this was J.T. Tokish, who was very thoughtful about this. They looked at a retrospective review of patients who underwent arthroscopic Bankart repair, and they looked at their redislocations. Patients who had on-track lesions, so again, not just looking at glenoid bone loss or humeral head bone loss, but looking at, classifying it as on-track, only an 8% redislocation rate. When you look at the off-track patients, 3/4 of them redislocated. So, the positive predictive values for redislocation, if you look at an off-track lesion, it was 75%. If you looked at just glenoid bone loss, it was only 44%. So they concluded that glenoid tract method may be superior to glenoid bone loss alone when evaluating for redislocation. Now, again, in real life, we're going to have all these factors as inputs, but I think this is just a sort of a better way to sort of think about all the pathology that's present and not just try to sort of oversimplify by just looking at the glenoid side. So how do we deal with that Hill-Sachs lesion? There's a couple ways, but what's been popularized, and again, I meant the common theme, what's old is new again. Jean Wolfe described remplissage 30 years ago, and it's from the French word to fill, where you basically do a posterior capsulodesis and the tenodesis, the infraspinatus tendon, into the humeral head, defect. So what you see on the video there, this is, again, looking from superior to inferior. That's that Bankart lesion anteriorly. The labrum is torn off the glenoid there, which, again, we'll fix arthroscopically. And if that was all that was here, they would do great with just an arthroscopic Bankart. The problem for this patient is they had that deep medial Hill-Sachs lesion, what we're looking at here. So for that reason, we had to do a remplissage or something to address this Hill-Sachs lesion. So this video is from a couple years old at this point, one of the nice things, and part of the reason why I'm doing this a lot more now is with some of the newer implants, doing a remplissage, which used to be an 8 or 10 minute procedure, is now 4 or 5 minutes. And when you combine that with the fact that all the data would support better results, I've gotten much more aggressive about using this. The theory of the remplissage is that you're converting that defect from an intra-articular defect to extra-articular, which is going to prevent that engagement of the Hilton sacs with the glenoid rim. So you're converting that off-track lesion into an on-track lesion. So again, now we're not going to fall into that pothole, which is good news. So this was a study looking at the indications for remplissage as it's gotten more popular. It was a consensus statement by an Anterior Shoulder Instability International Consensus Group. Full disclosure, I wasn't invited to participate, which is why I don't agree with some of these contraindications. I probably was. I just probably chose to play golf instead. But all kidding aside, looking at the relative indications, again, large Hill-Sachs lesion, off-track lesions based on preoperative imaging, or, again, this is also something that can be decided at the time of surgery. You can get that humeral head or that Hill-Sachs lesion to engage by moving the arm around at surgery. And if I see that, I have a very low threshold, or basically no threshold, to not do a remplissage. Relative contraindications, they talked about small Hill-Sachs lesions, ones that don't engage. And again, this was published in 2022, based on a survey done in 2020. I think over the last 5 years, we've even changed, and you'll see some of the data to support that. Severe glenoid bone loss, that's where, again, at that far end, that 20, 25%, I'm going to do a Latarjet and I'm not going to do a remplissage. Overhead athlete, that's something we could debate, because initially there were some studies that would say that you're going to make them too tight in external rotation. Other studies have shown this to be less of a concern. So that's really not a contraindication for me. This was looking at arthroscopic Bankart with and without remplissage, and it was a randomized controlled trial. Again, patients over the age of 14 with less than 15% glenoid bone loss with an engaging Hill-Sachs lesion. So an off-track lesion, and they were randomized. Postoperative instability was higher in patients without remplissage, almost 4 times the amount. So a 4% recurrence rate in the remplissage group versus almost 20% in the no remplissage group. I mentioned, external rotation loss. They did find decreased external rotation in abduction in the remplissage group, which may affect, depending on the athlete, a baseball player or somebody who has to throw and bring their arm all the way back. So it is a consideration. It's a relative contraindication, maybe, but not a strict contraindication. Outcome scores were similar. This looked at remplissage. So again, for me now, off-track lesions with less than 20% bone loss, I'm going to do a remplissage basically in everybody. How about doing it in on-track lesions where there is still, a small Hill-Sachs lesion, but it's not an off-track lesion? And again, on-track lesion, minimal glenoid bone loss or subcritical, again, that 13 to 17% range. They found no differences in external rotation and no differences in dislocation recurrence in the group. So I think for me, adding these patients, adding remplissage, there's very limited downside, but almost all studies at this point will show that there's a lower redislocation rate. What about comparing remplissage versus Latarjet? I mentioned that Latarjet works great, in the hands of a Gilles Walsh who's done thousands. That said, there's a very high complication rate, particularly, if you look at J.P. Warner did an elegant study looking at his first, 50, he had almost a 25% complication rate. Famous, outstanding shoulder surgeon with a 1 in 4 complication rate. That's not great numbers when you're starting to counsel a patient preoperatively. So there are, and some of them are bad. If somebody gets a little stiff, okay, not the end of the world. A fibrous union of a bone block, as long as they're doing well clinically, is not the end of the world. But early arthritis, nerve injury, those are bad complications. And if we can, avoid those by getting similar results with an arthroscopic procedure plus remplissage instead of doing a Latarjet, that becomes, I think, a big victory for our patients. So this was a systematic review and meta-analysis looking at arthroscopic Bankart, 4 studies that compared remplissage versus Latarjet with an engaging Hill-Sachs lesion and, again, subcritical glenoid bone loss. They found similar rates of postoperative instability, similar outcome scores, similar internal and external rotation, but a much higher complication rate in the Latarjet group, 9% versus 1%. So they actually didn't specifically say what the complications were, but again, what I showed on that last slide, screw impingement, sometimes early arthritis. So while some are relatively benign, others were more severe. So this is a study looking at remplissage for anterior instability. Just again, does it work? Now, it looked at 12 studies comparing 3 groups: arthroscopic Bankart alone, arthroscopic Bankart plus remplissage, or Latarjet. And in summary, they found that the recurrence rate between remplissage versus Bankart alone was significantly different. So definitely do remplissage over just a Bankart. And there was no difference in recurrence rate or revision rate between remplissage and Latarjet, with, again, much lower complication rate in the remplissage group. So for me, all the data at this point would at least support doing, in that subcritical bone loss group, arthroscopic Bankart plus remplissage, as opposed to just an arthroscopic Bankart or a Latarjet. Clearly, remplissage is not without concern. I mentioned potential loss of external rotation, persistent posterior shoulder pain. These have not really been borne out very significantly. And again, in most studies, if there is a decreased external rotation, it's less than 10 degrees, which for most athletes is not going to be clinically significant, but worth mentioning to them. So to conclude, obviously anterior instability is very common in athletes, and I think conventional wisdom and the literature now would suggest fixing the first-time dislocators. Arthroscopic stabilization provides excellent outcomes with a low risk profile in the appropriately selected patient. However, there are patients that still need more. I classify it as sort of arthroscopic plus, with a real focus on remplissage. And again, when you get to when the bone loss is too significant, nothing arthroscopic is going to help that, or I shouldn't say that. Nothing short of a bone block procedure is going to help that. And that's where we're going to consider a Latarjet. I think you guys had a lecture here a couple weeks ago, one including a colleague of mine talking about AI and it's the future, and we can't. It's all around us. I think shoulder instability becomes one of the perfect sort of uses, because there's so many different inputs, so many different, variables to factor in, from demographic variables to patient, desires in terms of sports to bone loss to tissue quality, that eventually this will be able to kind of tell us that for a given patient, this is the exact procedure that's going to provide them with a great outcome, low complication profile, risk profile, and the highest return to sport. Thank you.